Good afternoon, everybody. I am Russell Fleming. I am the Communications Manager for the ME Association. I'm going to talk to you today about the similarities between ME CFS and Long Covid and also the differences. We're going to look at the National Institute for Health and Care Excellence clinical guidelines for ME and Long Covid. And we're going to look at the differences between the two conditions. We're also going to cover some of the management advice, and then we'll have time hopefully for some questions and answers towards the end. So let me just reduce my screen. So there's rather a few acronyms used when we discuss these illnesses. Post-viral fatigue syndrome, ME can be myalgic encephalopathy or myalgic encephalomyelitis. CFS, chronic fatigue syndrome, which tends to be favoured most by GPs, but it's not favoured by the patient community because it tends to trivialise what can be quite a serious condition. And then you have Long Covid, which is again, the common name for the condition, but it has various other names, post-acute sequelae of COVID-19 or PASC or post-COVID syndrome. So the ME Association itself provides vital support, reliable information, medical training. We campaign and we invest directly in medical research. We've been here since about 1980. I think we've established a really good reputation over the last 43 years, and I believe that we deliver very high standards of support and information. Our ethos, if you like, is that nobody should struggle with these illnesses alone. There's been a lot of stigma around ME CFS in the past. This, I think, has changed now, particularly with the new NICE guideline, which was published in October 2021, and hopefully medical opinion, as well as opinion in society at large, has also improved because of Long Covid. I think because of the big numbers of people affected by Long Covid, it has made people appreciate that post-viral fatigue syndromes are very real and they do affect people quite badly. So during the pandemic, as a charity, we were quick to recognise the similarities between ME and Long Covid, especially around symptoms, which we're going to look at, and effective management. And we've been welcoming people with Long Covid ever since. So we provide support to help people through all stages of their illness. We believe that everybody should be entitled to the very best health and social care and access to the welfare benefits that they might need. We've been putting a lot of effort over the last 10 years into getting NICE to review and update its clinical guideline. And now we're spending a lot of resource to get the NICE guideline recommendations implemented across the UK. Medical research, we support the ME CFS Biobank. We fund the operational costs and have done since 2011. We support Decode ME, which is examining genetics in people with ME CFS and in Long Covid. We also directly fund research ourselves, largely of a biomedical nature, but we also look at, or we will also consider other forms of research. For example, one research study that's likely to be granted will be looking at patient-reported outcome measures in ME CFS specialist services. We're quite unusual as a charity in that we don't employ an expensive CEO. We tend to have trustees, several of whom provide day-to-day management oversight. We also have myself as head of communications. We have Vicky Smith, who's head of finance and operations. And then we have Hilary Bryers, who's head of ME Connect which is our support and information service. I don't want to dwell too much on us. What I will do though is I'll make this presentation available to anybody who wants it afterwards. This is also just to say that I recently wrote for our magazine, or well, it wasn't recently, was it? Christmas 2021. There's a story about me surviving ME. So I've had ME for 23 years. Took a long time for me, about 10 years, until things started to stabilize and then slowly improve. But I can make the story available as well. Seemed to resonate with a lot of people. So ME, CFS and Long Covid, quite similar in terms of that there's often a triggering infection. We believe from the research that's been done, around 80% of people who develop post-viral fatigue syndrome, or ME, CFS, can trace the onset back to an infection that is often acute. The types of infection, it really does vary. It can be any infection, to be honest. Glandular fever is the most common, but then so is the flu. Previous coronavirus outbreaks, SARS and MERS, have also led to ME/CFS-like illnesses, where people have just not been able to recover at around 6 months, and they meet the criteria for ME/CFS. Even Ebola has a similar characteristic, and of course COVID-19 in long COVID. So research, and I should say that there really hasn't been the kind of in-depth research we would like to see, but the research that has been done suggests that around 5 to 10% of people who are acutely affected by an infection are at risk of not recovering fully and developing a chronic disease state. This has been put into the spotlight with long COVID, obviously. So post-viral fatigue syndrome, the main symptoms are often similar to the triggering infection. In fact, as a patient, it can be very hard to determine between the infectious symptoms and post-viral fatigue syndrome symptoms, or ME symptoms, or long COVID symptoms. It can all feel very similar. So there are additional complications or damage, either from the virus, which is what we see with COVID-19, then resulting in a loss of mobility and this inability to get back to the degree of health that you enjoyed before you had the infection. So post-viral fatigue syndrome is recognised as a neurological disease by the World Health Organization. The international classification of diseases is recognised the world over, and the NHS and the UK government use it. In fact, the NHS uses the ICD coding system. So when you receive a diagnosis from your doctor, he will allocate a code based on the ICD. ME/CFS is included in that definition. At the moment, long COVID isn't. We're just waiting to see where they're going to classify long COVID. So both long COVID and ME are caused by an apparent failure to recover from a viral infection and share many symptoms in common, but also some differences, which we'll look at briefly in a moment. And I've said that. So the 21 NICE guideline, which provides recommendations to the NHS, so to your GP and to specialist services, they recommend that people with ME are diagnosed within 3 months of symptoms developing, which is exactly the same diagnostic period as people with long COVID. So what causes ME? We talked about the gene study that's currently undergoing. It's the biggest we've ever had. They're examining 20,000 people with ME and some people and a cohort of people with long COVID to try and determine if there is a genetic abnormality or something wrong within the genes that makes us more susceptible. We've seen that within ME, more than one family member can be affected. There's a similar high proportion of women affected than men, as there is in long COVID. But we also see parents and children affected, which is something we hope that this genetic research might unravel. So we talked about precipitating factors. These are the triggers, so infections, but also in ME, they may be triggered by an immunization, a vaccination, or exposure to a toxin or pesticide. So what keeps these symptoms going? What makes people continue to be chronically ill? So research has uncovered various abnormalities all over the body. What we need within ME research is much more funding so that we can explore some of these interesting findings to see if they are actual findings or not. So I think most people are familiar with the lack of energy, and there was some good research done investigating the mitochondria, which are often referred to as the batteries of the cells. And what it concluded was in ME that the mitochondria were working fine, but there's problems upstream of the mitochondria. So what's happening is that, or what seems to be happening, is that when food is converted to energy and then it supplies these mitochondria so that your cells can function properly, that conversion process is not working properly in people with ME. ME is defined as 4 severities. Again, I think this is quite similar to what we could define long COVID, but nobody's actually defined it in this way yet, I don't think. Mild, moderate, severe, and very severe. So mild, people might be able to work, but are likely to have stopped all leisure and social pursuits, to very severe, where people are confined to their beds 24 hours a day and reliant on care and support. I should add that deaths have occurred in ME, literally people wasting away, but it is still uncommon. So this is the NICE guideline. This is what they have to say about ME/CFS. So it's a fluctuating condition in which a person's symptoms can change unpredictably in nature and severity over a day, a week, or longer. That doctors should recognise that people with ME may have experienced prejudice and disbelief and could feel stigmatised by people who do not understand their illness. What the NICE guideline has done is it has recognised the problems that patients face. We worked very hard, as I said, to get the NICE guideline published. It took 4 years to write the new guideline. And now the hard part is to try and get all these recommendations implemented, to get doctors more aware, make doctors feel more confident in giving diagnoses, and to try and get hospital-based referral services in place in every county of the UK. So in order to carry out a diagnosis, again, this is quite similar, I think, to long COVID, but we'll come on to that. A person's got to have all of the persistent symptoms below. There are 4 of them for a minimum of 6 weeks in adults and 4 weeks in children. The person's ability to engage in occupational, educational, social, or personal activities is significantly reduced from pre-illness levels, and symptoms are not explained by another condition. So a doctor should run a specific set of tests to exclude other things that might be causing a person's symptoms. There's no diagnostic blood test for ME, unfortunately. So the diagnosis is made by careful clinical assessment and on symptoms alone. So these are the 4 main symptoms required for a diagnosis. And as you can see, they're exactly the same as they are in long COVID, more or less. Debilitating fatigue that is worsened by activity is not caused by excessive cognitive, physical, emotional, or social exertion, and is not significantly relieved by rest. Post-exertional malaise after activity, in which the worsening of symptoms is often delayed in onset by hours or days, is disproportionate to the activity, has a prolonged recovery time that may last hours, days, weeks, or longer. Unrefreshing sleep or sleep disturbance, or both, which may include feeling exhausted, feeling flu-like and stiff on waking, broken or shallow sleep, altered sleep pattern, or hypersomnia. And finally, cognitive difficulties, sometimes described as brain fog, which may include problems finding words or numbers, difficulty in speaking, slowed responsiveness, short-term memory problems, and difficulty concentrating or multitasking. So in order to get a diagnosis, it's necessary to have all four of those symptoms. There are other common symptoms, but they don't necessarily constitute a diagnosis. So again, I mean, as you'll see, as you'll know, orthostatic intolerance and autonomic dysfunction, that could include POTS, postural orthostatic tachycardia syndrome, temperature hypersensitivities, twitching, myoclonic jerks, flu-like symptoms, used to be a classic one, flu-like symptom, intolerances to alcohol, certain foods and chemicals, heightened sensory sensitivities. That's particularly true of people severely and very severely affected. So they can't tolerate light, sound, touch, taste and smell. Not necessarily all of those, but again, very similar to long COVID. And then pain, obviously. And then with severe and very severe ME, there's further additional symptoms, just highlight a few. So reduced ability or inability to speak or swallow. The cognitive difficulties become so severe that they are unable to write or to verbally communicate. And there we have POTS, double vision and other disorders, gastrointestinal difficulties, nausea, incontinence, constipation and bloating, and generally an extreme weakness. So people with severe and very severe ME, this is all from the NICE guideline, need a low stimulus environment, dark, quiet rooms, minimal interaction. It can be very, very hard communicating, if not impossible, which makes it very, very hard for loved ones who are often primary carers. So once a diagnosis has been made at 3 months, NICE recommends that adults in particular are referred directly to an ME/CFS specialist team. And these teams are usually based in local hospital. And then children are referred to a children's specialist team or to a paediatrician if a specialist team isn't available in their area. We have difficulty at the moment, as I said, we're trying to implement these NICE guideline recommendations, which is very hard because it's often a postcode lottery, depending on where you live, whether you've got an ME service at the hospital. It's also a bit of it's a lottery to try and get access to these services where they do exist, because often people are so unwell, they can't make the travel, they can't attend physically for very long, takes too much out of them. So again, NICE recommends remote appointments, remote attendance where possible, and that's something else we're trying to do. In Scotland, Wales and Northern Ireland, there aren't any ME/CFS specialist services. Similarly, a real lack of long COVID clinics. So it's an uphill battle at the moment, given the NHS's current situation and all the problems it's facing. But we'll carry on regardless over the next couple of years to try and get all these recommendations implemented and improve health and social care. So what happens when you get, if you are lucky enough or you are able to get to an ME CFS specialist service? They carry out a holistic assessment. So they look at the whole person, they consider everything. They confirm a diagnosis with a medical assessment. They review the impact of the symptoms on the person. They examine physical functioning. They consider medicines, drugs. So there are no specific drug treatments for ME, but there are some drugs that can be prescribed that will help with some of the symptoms. For example, pain management, sleep, and with managing mental health. I should add that with a condition like ME, it's completely understandable people struggle with their mental health. And you know, it's vital that these specialist services also provide help coping with the illness. They also look then at activities. They try and provide support for daily living activities. They should discuss work and education. Maybe that you've had to give up work or you're unable to attend work, but they should liaise with your employer or with your school or university. They should aim to produce a personalised care and support plan so that when you're discharged from the specialist service, you have a support plan in place that is then reviewed regularly by your GP. And that support plan might include re-referring you back to the service if you have needs. Specialist service should also be able to liaise or to help you with benefit applications. Again, sometimes if you don't have a specialist service, then this can be a GP's, something a GP should do. You often need a medical report to support benefits applications. So managing ME, the NICE guideline is very clear about incorporating physical activity and exercise. So do not advise people with ME to undertake exercise that is not part of a programme overseen by an ME CFS specialist team, such as telling them to go to the gym or exercise more, because this may worsen their symptoms. Only consider a personalised physical activity or exercise programme for people who feel ready to progress, would like to incorporate physical activity, and tell people about the risks and benefits of physical activity and exercise programs. Explain that some people with ME have found that they can make their symptoms worse. For some people, it makes no difference, and others find them helpful. Essentially, exercise has caused harm in some people when prescribed as graded exercise therapy, which is NICE has removed graded exercise. There we go. Sorry, I thought it was there. Yeah. So graded exercise therapy has been removed as a recommendation from the NICE guideline. Do not offer people with ME any therapy based on physical activity or exercise as a cure. Do not offer generalised physical activity. Any programme that does not follow the approach above or that uses fixed incrementally. This is graded exercise therapy. So what you would do is you'd establish a baseline, the minimum that you could do, and then you would increase those physical activities by a certain percentage each week, regardless of how your symptoms worsened or, you know, if they didn't worsen. But that's been taken out now. Yeah, so primary care have been asked to review the care and support plans at least once a year with patients. There's a lack of continuity of care at the present moment in time. People with ME often, because of the severity of the symptoms or because of the stigma that they felt in the past, they can exclude their GP completely. So they don't actually get to see a doctor. But hopefully, if the new recommendations are put into place, we can, build relationships again between patients and doctors. I think I said there's around 265,000 people in the UK with ME, or so we think. But when you compare that to 1.8 million people with long COVID, it's not a lot, is it? So there's 4 times more women affected than men. ME is most likely to develop between the ages of 10 to 19 and 30 to 39. And we think that the majority of people remain undiagnosed and not getting any help or support. Sorry, I struggle to see my own slides now because I've got all this Zoom stuff. Right. Don't think I need to go through that. Yeah, so with long COVID, more and more research keeps coming out, so it's quite hard to keep track of where we are with research findings generally, but fatigue continued to be the most common symptom reported as part of individuals' experience of long COVID, or at least this research, yeah, this was from the Office of National Statistics in April last year, so I probably need to update this slide a bit. So fatigue was the most common symptom at that time, 51% of people, by shortness, and then shortness of breath, loss of sense of smell, and difficulty concentrating. So prevalence of self-reported long COVID is greatest in people aged 35 to 49, females, people living in more deprived areas, those working in social care, teaching or educational healthcare, and those with another activity limiting health condition or disability. Here we look at long COVID and ME. What do long COVID and ME CFS have in common? So we've talked about more clinicians and researchers are now regarding ME and long COVID as examples of post-viral fatigue syndrome, which is what I talked about. They're both fluctuating illnesses in the sense that, the severity of your symptoms or the symptoms themselves can vary from day to day or hour to hour, week to week. There's no effective treatment management in the form of drugs. We tend to rely on self-management approaches, activity management and pacing, which we'll talk about, I think, in a moment. And then it's very similar. Women are 4 times more likely to have it than men in ME, and it's a similar rate in long COVID. Key symptoms in common: post-exertional malaise, we talked about, the profound exhaustion. Fatigue as a word is again disliked by the community because it just doesn't seem to do justice to the debilitating exhaustion. Muscle aches and pains, sleep problems, sleep quality, unrefreshing sleep, cognitive dysfunction, so brain fog has been talked about a lot within long COVID, I think. Very similar, if not the same, to ME. Dizziness, vertigo, and nausea, again, the same, similar. Bowel and bladder problems, sort of an irritable bowel type problem, fluctuating between bouts of diarrhea and constipation in some people. And then I've just put together some images of things that you've got in common. So with long COVID, we talked about fluctuating symptoms. New symptoms may appear as time goes on. So when you had your COVID infection, you may well have had a certain set of symptoms. And then as you were unable to recover, as other people perhaps were, you may well develop more symptoms as time goes on. You may also be affected mildly to very severely. Again, similar as in ME, different people are affected differently. Again, we don't know why. You may be able to work, you may not be able to work, you may have to give up work, etc. So some of the symptom differences with long COVID, you may still have this persisting shortness of breath or cough. Chest pains, they can be a difference between ME and long COVID, although people with ME do experience chest pains. Heart rhythm disturbances, cardiac arrhythmias, palpitations on exertion. People with ME do experience palpitations, but it's not a common symptom within ME. You may experience periodic fevers with long COVID. The loss or change of taste, medically known as parosmia, and or smell, very characteristic, isn't it, of long COVID. There are a few other things there that are differences. One of the key differences between long COVID and ME is the effect that the COVID-19 infection has had on organs in your body. Again, doesn't happen to everybody with long COVID, but you'll be aware that COVID-19 can affect your lungs, your heart, kidneys, etc. So when you're referred to a long COVID clinic, one of the first things they should do is triage you to refer you to specialists in cardiac or respiratory medicine, for example. And then you come back to the long COVID clinic essentially to hopefully learn how best to manage your condition. So here, the perpetuating factors are what keeps long COVID, what keeps you in a chronic state of ill health. So we talked about the damage to the organs that may have occurred. And then there are factors similar to ME, immune system dysfunction, antibody production, mitochondrial dysfunction. The amount of money that's being pumped into long COVID research, hopefully we'll get some answers soon. And also there's been a lot of talk in the media, hasn't there, about persisting viral infections. Is COVID-19, does it remain a persistent problem within the body? Is it causing these symptoms? And then there's also been a lot of media talk about these small blood clots or microclots, but we're a bit cautious on that because we don't think the research is there yet. We think there's been a lot of speculation about it that shouldn't have been perhaps made yet. So ME has got a nice guideline. This is the framework of clinical recommendations that are made to the NHS, and long COVID has a rapid guideline. It's not as thorough as the ME guideline. In fact, there's a lot to be said that perhaps they should merge the two guidelines. But I can provide you with links to the long COVID guideline if you like. But what it does mean is that when you go and see a GP, well, you probably already have done this, but when you go and see a GP, you should be able to just pull up the nice guideline on long COVID in order to find out how to diagnose you and what to do about management and what to do about referring you to a long COVID clinic. So you get to the Long Covid clinic, and as I said before, they should offer you tests to rule out acute or life-threatening complications, or that could be a new unrelated diagnosis. After an holistic assessment, they should discuss with you the options available and what each involves. So advice on self-management with the option of supported self-management. And then they should be giving you support from an integrated and coordinated primary care service, from the community rehabilitation and mental health services, or you should be referred to an integrated multidisciplinary assessment service, or referred to specialist care for specific complications. What all that means is you get, as I said, you get triaged upon referral and referred to specialists if and as you need them. But if you stay within the Long Covid clinic, you should be getting advice on self-management, the best way to help you manage your condition, and access to mental health support if you need it. I'm a bit conscious of time now. Yeah, that's right. So just have that one slide. Oh, no, lost my slide now. I'll stop sharing. I'm just going to try and stop. Sorry, excuse me a minute. I seem to have lost mine. Oh, there we go.
I've stopped your sharing there for you, Russell. Thank you so much for that. It's really interesting, and it's one of those topics I think that we could have probably talked about all day, because there's so much information, isn't there? You know, sort of in there. I guess one of the things just mentioned for people coming late, we are going to share slides after the event. And we're also recording the presentation, so that will eventually be available via our YouTube channel. We have got people from, I think, across the country actually in this session, which is great. Just to kind of run through, I'll have a little look in the chat and see what questions we've had. I know that one person mentioned just about how, you know, sort of heartbreaking the video was that you showed, and obviously, you know, sort of it was, you know, sort of very, you know, emotional. And for people who turned up late, obviously they can see that. Is that also available via your website in case anybody wanted to view that?
Yeah, I think we can, if I give the link to the presentation, and if people download the presentation or watch it online, it should be accessible.
Brilliant. We also have a message, I guess, about you know, what can we do nationally to raise awareness with clinical professionals, especially GPs, who, you know, sort of, who would help patients with diagnosis, support and referral to appropriate services. I guess their experiences at the moment, patients are still kind of feeling ignored or dismissed, or even kind of labelled as vexatious. So I guess there's obviously the NICE guidelines, but, you know, how would you kind of recommend, you know, sort of people getting raising awareness, you know, in that way?
Well, I think in other parts of the country, in Scotland as well, where I've delivered these presentations, and we've had follow-up sessions to talk about management options and things, they've formed support groups, and I think that's a great way of not only meeting other people with the same condition, but talking about ways in which you know, NHS provision is good in your area, or perhaps where NHS provision isn't so good. You and I spoke before this meeting about Long Covid clinics in the Northumberland area. It may be, you know, if you join together with other people with Long Covid, you could talk about, you know, how effective these clinics are, and then speak to the clinics themselves, or speak to us, you know, the ME Association.
Yeah. I think certainly, as you know, Health Watch, we would also be interested in hearing from anyone, you know, sort of with experience of, you know, sort of healthcare services, and, you know, sort of access to that support, whether that's good, bad, you know, happy or sad. And there will be Health Watch in every area. There is a Health Watch in every area of the UK. So if you're not from Northumberland and you're on this call, you can, you know, sort of make contact with your individual health watch to kind of share that feedback. It all goes through to the people in charge of running those services. So we also have another, I guess, comment just saying it's a real kind of challenge for employers to apply understanding of how to support staff as well with the condition. So I guess obviously there is things that, you know, documents that kind of promote it through public health and ACAS, but obviously some employers don't kind of engage in it. So again, I guess, you know, is that kind of a role for, you know, sort of yourselves to support?
So we've got we're actually delivering, or one of my colleagues is delivering a presentation we've been working on. I can't for the life of me remember who it is, but it's the start of an initiative we want to do. We've got ACAS lined up. This initiative I'm thinking about is with another employment organisation. But basically, we want to go on the road with HR departments, big employers, the Federation of Small Businesses, people like that, to raise awareness not only of ME and long COVID, but of any other, of all chronic health conditions that affect employment, just to work with employers on, you know, how they can help members of staff who are able to work part-time or full-time, and how they can support members of staff who are unable to work. In fact, if you go to the ME Association website and you look in the website shop, there's a recently published a booklet, Employment Issues in ME. It's quite a thorough, well, it is a very thorough document listing all the issues that people might have with employment, suggesting, you know, how you can resolve them and providing all the information you need. It's written from the patient perspective. Sorry, I don't mean to keep referring to patients, but it's written from the people with ME or long COVID perspective, not so much from the employer's perspective, but I think it's useful. It's a useful document for employers to look at as well as employees. Again, I can provide a link to that.
Great, thank you for that. So just some other things. Obviously, we have had a couple of comments just kind of saying thank you, and obviously the slides would be really useful to refer to in appointments. Someone's asked about where you start with the extreme fatigue, for example, when someone's kind of bedbound, unable to feed. Obviously, you know, sort of you've gone through that. Is there any advice you can give there?
I think it's not always easy trying to get a GP on board with the problems you face. It's not easy these days, is it, trying to get GPs to do a home visit? But it is possible. You really have to dig deep as a parent or partner of somebody who is in that sort of a dire situation, and keep trying to get your GP involved. If you can get him involved, if you can get him out to see how badly effective this loved one is, that is half the battle. If you know, because then they can start making the necessary arrangements to, for example, try and get you some home help, some help from social services if you need a paid carer, assistance with benefits, and clinical care, of course, to try and get, you know, if you need community nurse support, things of that nature. If you need help with aids and adaptations, disability aids and adaptations around the home, or even to the extreme of making home improvements to support somebody disabled to that extent.
That's great. Sorry, there's just lots of questions coming in, so let's have a look. So someone's asking if you can have more than one diagnosis. So
Yes.
Lisa has got long COVID and gone through rehab, but prior to COVID was extremely fatigued and feels that may have CFS or ME. And I guess what can be done now? So is it the case of going back to the GP to request like a referral to, you know, sort of like a specialist clinic?
Yes, I mean, you need to, in part, go to the GP. Although you've got an idea yourself of what might be wrong with you, you need to just let the GP go through and run all the tests to try and exclude what might also be causing your symptoms, because the rates of misdiagnosis are quite high in ME/CFS, and I suspect there might be in long COVID too, but we've got no research to confirm that. So what you want to do is, for example, something that can be confused with ME/CFS, if the doctor isn't particularly confident in making a diagnosis, is, for example, sleep apnea or thyroid disease. Or so what he needs to do is to be able to exclude all these other things, which may be perfectly treatable. I mean, if he or she is able to determine that you've got something else that is treatable, I mean, that's great news, isn't it? Because hopefully you can recover from those symptoms and get on with your life. So you need to go in to see your GP with an open mind about what you might have wrong with you. Let him go through, follow the NICE guideline recommendations. But it is perfectly possible to have more than one condition. You know, fibromyalgia is another one that I didn't talk about in the presentation. But you could, you could have something else. Yeah.
That's great. Yes, so there's been a reply just to say that there is a number of matching symptoms there. So there's quite a lot of similar sort of queries. I've had a direct message as well, just kind of saying that someone can only trace the CFS ME back to micro blood clots, pulmonary embolisms. Is that unusual? I don't know if you're aware of that. And also just saying that they're struggling to get a battle for a formal diagnosis. Any advice? So I guess that would possibly be what you said about all the NICE guidelines and.
Yeah, again, if you go to the ME Association website and you look in the website shop or the literature area of the website, we've got a NICE guideline summary that we've done as a free booklet, or you can go to the NICE National Institute of Health and Care Excellence website and just put ME/CFS in the search box or long COVID in the search box, and you get both the guidelines come up. They're the long COVID one, I wouldn't say is very easy to read if you're not a medical professional, but the ME one is certainly very easy to read. You can just download it or you can read it on the screen.
And is there any information on the website about this issue with the blood clots? And
yeah, so we have made a statement. If you go to the website again and you put in the search box, I think micro clots, I think we did make a statement about that research. It tends to be more connected to long COVID, I think, although they've also said it's a researcher in South Africa and there's a researcher in the UK who seem pretty convinced that there's evidence of microclots. We're just not sure the research that they've done is good enough, and they need to do it in much larger cohorts of people. But yeah, I think it's on the website.
Right. And another question about exercise. So just someone saying very interested in the exercise issue, but very wary of the advice and encouragement to simply go and kind of book a swim session. Very aware of own limitations and scared of the potential crash happening in a public place. I guess with a lot of long-term conditions, the natural advice is to, sort of do physical activity, isn't it? So
yeah. It is. So I think they went wrong. Well, I know they went wrong with long COVID when it was first being talked about, and the solution was exercise. Since then, I think they've come around to the ME's position on it. Both conditions have post-exertional malaise as one of the symptoms. And, if you push beyond your abilities with exercise, particularly, we're talking about aerobic exercise for most people, but even, gentle walking around the house, etc., can be too much for some people. But if you push beyond what you feel comfortable to do, yes, it can cause big setbacks in health. It can cause all your symptoms to flare, and it can lead to relapse. So the NICE guideline on ME is very, very clear. I tried to be clear in my presentation, but I was struggling by that point. It is quite clear on the recommendations around physical activity and exercise. So it's worth you taking a look at the guideline, I think.
Great. So someone else saying that they have ME, but the difficulty is getting GP to acknowledge new symptoms post-COVID. Interestingly, given antiviral medication for COVID due to having an anti-mitochondrial antibody syndrome, wonder if it's related to ME. There's a lot of acronyms, isn't there? That we might need to explain. Probably there's lots on your website to be able to help with that.
Well, antiviral medications are quite interesting. So essentially, if you have COVID-19 and you're in one of the high risk groups, this is as I understand it from memory, you could be offered antiviral medications. Now we have quite a few people with ME wanting access to these antiviral medications, but as ME isn't one of these high risk, it isn't recognised as a high risk illness by the Department of Health. People with ME can't generally get access to these antivirals. I'm not sure if people with long COVID, no, well, if you've got long COVID, yeah, I suppose you can still get COVID-19 again, don't you? But again, I don't think long COVID's recognised as a high risk illness. Did you say she had, it was mitochondrial? Sorry.
Due to anti-mitochondrial antibody syndrome.
Oh, right, okay. So that was presumably recognised by the GP as being a risk, a high risk, hence why she or he got antiviral medications. Yeah.
I mean, potentially if these questions aren't necessarily answered, presumably there is advice on your website and you can contact the ME Association for further information. Would that be the case, Russell?
Yeah.
That's great. I'm aware it's coming to an end, but we have only got, I think, one or two more comments anyways. So Lisa, who's a social prescriber, has come up with a very good, sort of valid, sort of comment really, saying that obviously as a social prescriber, and they're kind of linked to GP surgeries and basically helping people with those, sort of social elements to kind of increase well-being. They run a walking group, and obviously they will get patients with ME and CFS wanting to kind of join that walking group. And now, I guess, given the comments around, sort of exercise, if it's not approved by, sort of like a clinical, professional, should you be concerned about that, I guess?
No, I mean, it's important that everybody's different, okay? With ME, with long COVID, we can, we might find somebody who's similarly affected to us, but I can walk further than perhaps the next person with ME, or I might walk less than the next person with ME. So it's important to recognise and understand your own limitations, what you can and what you can't do comfortably and safely. So part of managing ME and long COVID is working on something called pacing. So I didn't have time to go into it, and we usually have a second presentation about this, but essentially you need to work out for yourself what you can comfortably do in a given day or week or fortnight without it causing your symptoms to exacerbate. So, what can I do today that I can do tomorrow, that I can do the next day? The minimum. And then over time, as you produce that minimum activity, can you comfortably improve on that minimum activity? It may be that you focus on a particular activity. So reading, for example, your minimum may be, I can read a page of a book, or I can read a paragraph or something. And then you then look to improve from a paragraph to a page to a chapter. Can I do these things without them exacerbating my symptoms, without me feeling worse, without it leading to a flare or a relapse? And then over time, hopefully, your symptoms stabilize as you implement this pacing program, and then will start to improve. And that's when you can start to increase activities.
So I guess as a professional then, all what Lisa just, sort of, obviously it's important that obviously people aren't excluded either. So it's really just about having a conversation about, sort of them being aware of limitations and maybe having, which I'm sure they do anyways, options for people to kind of, not necessarily having to do the full walk or whatever else. So, that's something that maybe, sort of she could take away, hopefully, and that's useful. I've put your email in the chat because someone's asked for that, and someone's asked to sort of said that they would love to see the presentation on pace, and I don't know if that's kind of publicly available.
Well, to be perfectly honest, I haven't written an actual presentation yet. What we tended to do with other groups is we've sort of got together again and we've just sort of exchanged tips, and it's been a bit of a back and forth so that everybody sort of asks questions and I can help where I can, or you can learn from other people, because that's quite often the best way. So if somebody's got a particular problem, or I don't know, it could be something to do with managing the illness, or it could be getting access to a GP or something in their area. Other people can often help them out, and that's a good way to do it. So I haven't got an actual PowerPoint presentation yet. It's something I'm trying my best to work on, but never seem to get around to it.
I was going to say, I'm sure it'll be updated on the sort of website as well.
If you want, as I say, start with the nice guideline. If you go to the website shop literature section, there's a whole section on management. It's got loads of leaflets in there. There's one on energy management and pacing, which gives you a basic overview of activity managing and that sort of thing.
Right. Well, we're coming to the end of the presentation now, so thank you everybody for joining us today and giving up your time to come along to this. As we've kind of seen, there's been so much interest, so much questions, and I'm sure that sort of after people go away and read through the slides, they may have more questions. So we know that Russell's email is in there. You can also get in contact with us at Healthwatch Northumberland with any questions, and we can pass that on as necessary, or feedback to health services. And just a reminder that if you're not in Northumberland, you do have health watchers locally to yourselves as well. So thanks everybody for coming along today, and
yes,
we will
thank
see
you ever so much
at our next presentation soon. Thank you.
Thank you all.